Well, in summary, for all types of dementia, classic risk factors vary depending upon their timing. During midlife, hearing loss, hypertension, obesity, emotional trauma, head trauma, ApoE, hearing loss, and lower educational status, perhaps because of less cognitive reserve, are predictive of late life dementia. And later in life, the presence of cerebrovascular disease, smoking, depression, reduced physical activity, social isolation, and diabetes become more paramount. Therefore, hypertension and obesity and ApoE gene status are predictive in midlife, whereas diabetes and cerebrovascular disease and smoking are more predictive when they occur as exposures in late life. In fact, in a fairly well-validated midlife dementia risk score, you can see that elevated systolic blood pressure and a BMI, low physical activity, and again, this ApoE4 positive status are highly predictive of subsequent late life development of dementia. Therefore, dementia in advanced age could be viewed as both a neurodegenerative and a vascular disorder, with both mechanisms being synergistic. But how do common illnesses contribute to dementia? Diabetes, high blood pressure, obesity, and in the cardiovascular literature, congestive heart failure, and even atrial fibrillation and coronary disease, the big three. Well, it's hypothesized that oxidative cell damage, insulin resistance, fat cell activity all create inflammatory stroke-like damage, which eventually goes on to result in dementia. Moreover, risk factors may be synergistic, as it was found that a cumulative number of vascular risk factors was associated with an increase in brain amyloid deposition, and also the greater the number of risk factors, the earlier the onset of dementia. But what about the specific risk factors? Well, we talked before about their occurrence at different times of a person's life. We differentiated midlife versus late life onset and spoke about how hypertension and obesity were midlife cardiovascular risk factors, whereas diabetes and cerebrovascular disease were more predictive in late life. Well, as it turns out, when we're dealing with patients in late life, they've had cumulative exposures to the various cardiovascular risk factors. So it's important to look at trajectories of the various risk factors. This is a slide showing blood pressure trajectories from midlife to late life in women who did and did not develop dementia, who were followed for over a 37-year period. The dashed line is dementia cases, whereas the filled-in line is non-dementia cases. And as you can see, their blood pressure rises more rapidly in the dementia group, but then falls more precipitously in the dementia group as compared to the non-dementia cases. Therefore, it appears as though the blood pressure trajectory is novel to that of dementia, in that while all subjects have a rise and then an eventual fall in blood pressure during aging, these changes are more marked in patients with dementia. So what happens in blood pressure and dementia? Numerous papers have shown that blood pressure rises decades before cognitive dysfunction, and blood pressure elevation may promote the development and the progression of amyloid and tau neuropathology. Patients with dementia exhibit a greater longitudinal blood pressure decline, as well as a steeper rise in midlife. Low blood pressure late in life in patients on medications is actually highly predictive of dementia 2 years later. Specifically, steeper reductions in diastolic blood pressure over 20 years was found related to greater cortical atrophy. And moreover, low diastolic blood pressure was found related to smaller hippocampal and amygdala volumes. So there's an emerging literature to show that changes in blood pressure along a patient's age trajectory may be important indicators and potentially impact upon the course of dementia. Now, this drop in blood pressure in late life is actually a very interesting phenomenon. It is associated with greater all-cause mortality and greater frailty as well. And when you look at other trajectories of cardiovascular risk factors, such as obesity, they actually demonstrate a very similar pattern. Shown above is the trajectory of body mass index over 28 years in the Whitehall 2 study. And look, the dementia group shown in red has a greater rate of rise, ranging from 28 to 12 years before the onset of clinical dementia. And then the patients who eventually go on to develop dementia have a more rapid decline in body mass index. So, in summary, their blood pressure rises more quickly and then falls more precipitously, and so does their BMI. There's a greater rate of rise and a greater decline. What about cholesterol? Well, it turns out that hypolipidemia is associated with dementia. Dementia is associated with LDL cholesterol specifically, but not with HDL or high-density lipoprotein or triglycerides. And it turns out that this relationship between total cholesterol and LDL weaken with age. When one looks at cholesterol levels and incident dementia, again, using this trajectory analysis, once again, we see more rapid rises in total cholesterol and then more precipitous falls in patients with dementia as compared to those who don't. And this was seen in patients with both Alzheimer's disease and those with vascular dementia. So I think one can conclude that there is a novel and unique trajectory phenotype where weight loss starts to occur 10 years before the actual diagnosis of dementia, and blood pressure starts to fall 5 years before the diagnosis. And while the results are less consistent, falls in cholesterol show a similar pattern occurring nearly 3 years before the onset of clinical depression. C-reactive protein, a biomarker of inflammation, has also been found to be associated with the future of vascular dementia in this particular study, but not with Alzheimer's disease after adjusting for common cardiovascular risk factors, stroke, and competing risks of death. It's very clear that a peripheral blood marker of inflammation may not represent inflammation in the nervous system, particularly in patients with Alzheimer's type disease as compared to those with vascular dementia. And what about diabetes? Well, at any age, diabetes is associated with cognitive dysfunction. And when you look at the cognitive trajectories, they don't rise and then fall. They actually simply decline, and they decline in a much more rapid rate in patients with diabetes as compared to those without, even after adjusting for confounding variables such as birth cohort, practice effects, sex, education, and age. There was a meta-analysis of some 19 studies showing that diabetes increases the risk of developing Alzheimer's disease and the risk of mild cognitive impairment. Therefore, Alzheimer's disease and diabetes may share common risk factors, including metabolic syndrome factors, but it's been suggested that undernutrition may be problematic in patients with dementia, or that they may develop preferences for sweet foods or snacks, which worsen insulin sensitivity and heighten a patient's risk of developing diabetes. And since both diabetes and dementia are progressive and lifelong, the prevalence of these two conditions is increasing. And healthcare providers need to develop novel ways to deliver care for patients with comorbid Alzheimer's disease and diabetes.